Thank you, Chairperson. Thank you for the nice introductions. Today I'm going to talk about the long-acting injectable. It's actually a treasure. Whether it's underutilized, we'll see in the presentations. Schizophrenia is a severe and chronic illness that affects at least 2 to 3 out of 1,000 people around the world. It is one of the most disabling disease because of the early onset, chronic course, and frequent relapse. It requires a continuous long-term treatment to reduce the mood symptoms, improve the quality of life, and also prevent the relapse. The duration of treatment of schizophrenia depends on a number of factors, and it should be individualized. IPS guidelines says that in 2017 it was released, and it says that the first episode psychosis patient should receive at least 1 to 2 years of treatment. A second or multiple episode need to receive at least 5 years or longer period of treatment. But some patient may need a long-term or indefinite or lifelong treatment. For example, the patient who developed early onset psychosis, a relapse while reducing the antipsychotic dose, patient have a suicidal attempt or ideas, a strong family history of mental illness, and the patient have an incomplete remissions, they need a long-term and indefinite or lifelong treatment. Also, the patient who has multiple episodes and who has have a comorbid substance abuse, these are the patients who may need a lifelong treatment. So, there is a high rate of relapse reported in schizophrenia. Up to 50% of the patients, the relapse, 50 to 70% relapse within 1 year. Almost 90% of the patients, they relapse within 2 years. Lieberman and Korn et al. Reported that the high rate of poor drug compliance among the patients with schizophrenia. Within 1 year, almost 42% of the patients will stop medications, and 70% of the patients stop medication within 1.5 years. And that this treatment discontinuation lead to a 5-fold greater risk of relapse. It severely affects the patient's social and occupational functioning, and also it decreases the quality of life. So psychiatrists usually they tend to overestimate that the patient has been adherent to the medication. They think that the patient is taking the medication regularly. But in reality, only 50% of the patients they are adherent to the oral medication prescribed by the psychiatrist. As a result of the non-adherence, the patient may have a symptom exacerbations. They have frequent emergency visit to the psychiatrist. They have rehospitalizations, relapse, and treatment resistance. On the other hand, the patient was continuing the medications during the maintenance periods, result in only 70% reduction in the rate of relapse. So non-adherence is a problem throughout the course of illness, either the schizophrenia or bipolar disorders, any chronic illness. The non-adherence is the main issues. There are several factors contributing to the non-adherence, like lack of insight, direct impact of the symptoms like cognitive impairment, forgetfulness, secondary to positive and negative symptoms, drug adverse effect, social isolation, comorbid misuse, and stigma. And partial adherence is another issue, especially in patients with schizophrenia or bipolar disorder. The partial adherence means patient consistently miss the doses or take incorrect doses. If prescribe the medicine and the patient says that they will continue the medicines, then they ask for them, they say, when you check for the medications and they have missed the doses, they forget to get the dose, or they themselves reduce the dosage. For example, the patient has excessive sleep without asking the psychiatrist, they'll minimize the dose. That might be an inadequate dosage for the patient, which prevent the adequate dose only prevent the relapse. When inadequate dose, the patient will have a breakthrough episodes. So the level of adherence vary over the time for many individuals. For example, they take the 100% medication during the time of relapse. When they get improved and they are taking medications gradually will diminish. The non-compliance of schizophrenia occur very early, and actually 20% of the patients, the partial compliance start early by 7 to 10 days, 50% in 1 year, and 70% in 2 years. So So as the result of the non-adherence and partial adherence, the patient have a relapse, they have frequent hospitalizations, increased cost, and also the poor adherence patients have an increased risk of suicide. So most of the patients with first episode psychosis, they'll respond to the medication which you give, and often they return to the pre-mortem level of functioning. Within 1 year, 50 to 70% of the patients experience a relapse due to non-adherence. So recurrent relapse of psychosis can lead to decrease the treatment response. The patient might be responding to the previous medications, but when you get relapse, the patient may not respond to the medication which you give earlier. And there is a worsening of the disease process, there will be a brain damage, and also the patient have a damage in the individual's confidence, social networks, and also employment opportunities. So there is a need for an aggressive treatment to prevent the relapse is very, very essential to the patient, save the patient's neuronal, cognitive, social, and vacation time. So long-acting injectables play a very major role in treatment adherence, prevent the relapse, and also it prevents the neuronal damage, and also it improves the overall patient outcome. So long-acting injectables, traditionally it was been reserved only for the patient with the non-adherence with the oral medications, also for a long-standing chronic illness. But research evidence shows that the introduction of long-acting injectable in the early part of the illness can lead to positive outcomes like decreased rate of hospitalizations, decrease the relapse. So every psychiatrist should know what are the available long-acting injectable available in the market, how to use the long-acting injectable, and when to initiate the long-acting injectable, and when to switch from oral medication to long-acting injectables. So the first generation antipsychotic was introduced in 1950, and after the introduction, they found that there is a poor adherence to oral medications. So this led to the invention of the first long-acting injectable flufenazine deconate, ethanate in 1966, followed by flufenazine deconate 18 months later. The introduction of haloperidol in 1981 showed that there is a dramatic reduction in the morbidity of patients with schizophrenia. So the concept of long-acting injectable schizophrenia was initially not welcomed by the psychiatrist due to the fear that it will increase the side effect. The patient have whether it may have a efficacy or not. Then also the potential medical legal problem. They fear that the patient may develop a TD, they lead to a medical legal problem. These are all the hesitation was noticed in the initial stage by the psychiatrist, especially for using the long-acting injectable. However, subsequent surveys, clinical trials, and studies suggested that long-acting injectable was more beneficial than the oral drugs, and it was being widely accepted among the psychiatrists. The FDA approved 4 atypical long-acting injectable and 4 typical and 4 atypical long-acting injectable. The first generations are typical long-acting injectables are flufenazine deconate, flufenazine deconate, haloperidol deconate, suclopenthiol deconate. Also, the second generation antipsychotic long-acting injectables like risperidone concertizine IM injection. Recently, they introduced risperidone subcutaneous injections. It was recently introduced and used in the US market. And also the olanzapine palmate long-acting injectable, paliperidone palmate once a month, and also paliperidone palmitate once in 3 months also, injection also available. Similarly, aripiprazole once a month and once in 2 months injections available in US and UK. So at present we have 4 first generation long-acting injectable like flufenazine deconate, haloperidol, flufenazine, and suclopenthiol deconate, and 3 second generation long-acting injectable like risperidone long-acting injectable, and paliperidone once a month long-acting injection is available in India, and also olanzapine palmate is available. So first generation long-acting injectable was introduced in 1966, and it continues to be widely used even today in many parts of the world. In Snake Hospital, we are using more than 500 ampoules of flufenazine deconate every month. So first generation long-acting is flufenazine deconate available at 25 milligram. Flufenazine is deconate available in 20 to 40 milligram, and suclopenthiol 50, 100, and 200 milligram vial is available, and it can be used every month or every 15 days. Haloperidol deconate 50 and 100 milligram is available, and it's available. You can prescribe every monthly injections. So first generation Lele is very cheap. Fluid is a deconate just around 40 rupees, and this haloperidol around 50 to 200 rupees, and Suclopentixol is around 900 rupees. So it's very cheap, and major limitation is the more exorbitant side symptoms. It's one of the limitation for first generation antipsychotic. When compared to oral antipsychotic, many randomized controlled trials reported that first generation LA have lower discontinuation rate, reduced number of inpatient stays, and also reduced admission rates. So one of the major disadvantages for the first generation LAs are acute EPS, tardive dyskinesia, and hyperplaquemia. The advantage is it's very low cost, economically very cheap, and it has very less metabolic side effect like weight gain. So second generation LA was introduced in after the introduction of second generation LA, the declining the use of generation long-acting injectable, and second generation long-acting injectable was have a better tolerance and less side effect when compared to first generation LA. Second generation LA has a potential to prevent or reverse the frontotemporal gray matter decline, to provide a greater degree of neuroprotection than the first generation LA. So this second generation LAs have a neuroprotective effect by preventing the degeneration of the or decrease the frontotemporal cortical gray matter decline was prevented by the second generation long-acting injectable. And metabolic symptom is the only hindrance to the usage of second generation LA. So the respirator was the first LA, was approved by the FDA in 2003. It available at 12.5 milligram, 25 and 37.5 and 50 milligram. And this oral respirator, you should give oral respirator before giving an injection to ensure that a patient have a tolerability. And the steady state will reach only after the 4 injections. And you have to continue the oral respirator for at least 3 weeks before started tapering. And if you want to start, and after the injection, you taper this oral respirator over a week of 1 to 2 weeks. So respirator LA appear to be well tolerated. Only less than 10% of the patients experience the EPS, and the long-term studies reported that there is a fewer discontinuation rate because of the adverse effect. The prolactin level and TD were said to be low when compared to oral respirator. When you switch over to oral to long-acting injectable, then they also reported that TD and prolactin level was not that much high when compared to oral. And the only limitation is that it costs around 7,000 rupees. Around 50 milligram is cost about 7,000 rupees in Indian market. And olanzapine palmoate is available as the crystal form. Is available in 210, 300 and 400 milligram vial. Can be given once in 2 weeks or once a month injections. And is around 300 milligram of olanzapine long acting. The price is around 1,650 rupees. Once you open the vial and you reconstitute this olanzapine long acting, should be used within 24 hours. If it is more than 24 hours is over, you should not use it, you should discard. So the recommended dose is that if the patient is on 10 milligram of olanzapine, then you have to start with 210 milligram every 2 weeks or 405 milligram every month. You should give it for 2 months. That's 8 weeks. After 2 months, you can maintain the patient on 300 milligram every 4 weeks. If the patient is having a 15 milligram of oral olanzapine, then you have to give 300 milligram every 2 weeks. Then you have to maintain the patient on 405 milligram every month. If the patient on 20 milligram of oral olanzapine, then you have to give 300 milligram for every 2 weeks for first 8 weeks, and then you have to give 300 milligram every 2 weeks. So generally, our day-to-day practice, many of the patients will respond with the oral drug like 10 milligram is adequate for a maintenance dose of olanzapine. So after the initiation of 400 milligram every month for 2 months, then after that you can maintain the patient on just 300 milligram. I have been using almost for 5,000 injections so far, the olanzapine long-acting injectable, and the patient is doing extremely well. Many patients are doing extremely well, especially the schizophrenic patients on 300 milligram every month in the monthly injections. So you have to very carefully giving this injection, olanzapine injection. You should give in a deep intramuscular injections, and before giving the injection, you aspirate whether the blood is coming in. If the blood is coming in, then you discard the injection. You have to use a new one, and do not massage the injection site. Intravascular injection may be that you produce one of the important side effect called post-injection syndrome. The post-injection syndrome is otherwise called PDSS, that is a post-injection delirium and sedation syndrome. It probably is caused by the intravascular injections, and it occurs in very small number, like 0.07. It's about 1 in 4,000 injections, and the 80% of the patients develop symptom within 1 hour of the injections. So the symptom of post-injection symptoms like PDS is like sedation, delirium, confusion, dysarthria, ataxia, agitation, and anxiety. So the olanzapine should be administered only by the trained health professional. Only the trained health professional should give the olanzapine long-acting injectable, and the patient should be observed for at least 2 to 3 hours after the post-injections, and check for the alertness, orientations, any absence of any symptoms, PDSS symptoms. At least you will watch it for every 30 minutes for 2 hours before injections. And if the patient develop any of the symptoms, you should ask them to, immediately they should reach the doctor. So far I have been injection more than 6,000 injection, but I never come across any PDSS symptoms. But anyway, we should be very careful when you give this olanzapine LA. You should be very careful. You should watch for the PDSS, and the many clinical case report says it's an emergency. But so far, our Indian data, there's nothing was reported. So paliperidone palmitates is one-month injection was approved by FDA for schizophrenia in 2009, and it has been approved by European Medicine Agency in 2011. It's available as once-a-month injection and once in 3 months injection. It is water-based formulation, and in India it's available as 50 milligram, 100 milligram, and 150 milligram of injection is available. And first dose, first day you should give 150 milligram in a deltoid region. After a week, after 8 days, you should give 100 milligram in a deltoid muscles. After that dose, you should give once a month 100 milligrams. So this is a standard protocol recommended by the drug manufacturer. And following the second dose, initial dose, the monthly dose can be either given in the deltoid or the gluteal region. So first 2 doses you should give only in the deltoid region because of the early absorption, and so that for respiratory you have to give oral dose. Maintenance, you have to give a oral dose along with the respiratory injections. But in paliperidone injection, there is no need to give an oral dose. Straight away you can give these injections because if you give a deltoid muscles and the first and second injection, the patient they reach the steady state level very fastly. There is no need of giving an add-on paliperidone oral tablet along with these injections. So some patient may benefit in a lower dose or around 50 to 100 milligram or individual because based on the patient tolerability and efficacy, you have to choose the dose. But generally the patients initially you give 150 and 100 milligram as per the schedule, and most of the patients they will be maintaining only on 100 milligram every month. So I have been using these injections, paliperidone injection for the past 3-4 years, and I would say that because the Invega Sustana injection was available and it's Johnson is very costly, it's around 11,000 rupees. Recently Sun Pharma has launched their injections, Paliris, and just it was around 2,700 rupees, 100 milligrams, and we have given more than 200 injections for the past 6 months. And many of the patients they are doing well with 100 milligram of paliperidone LA, and every 4 months they are doing extremely well. So Aripiprazole LA in 2014 is approved by this FDA for the treatment of schizophrenia as well as the bipolar 1 disorders. It is available in 400 milligram, is monogated monthly injection, and once in 2 months is around available in 441 to 1061 milligram in a vial. And both this injection was not available in India, but in US and UK, they said that it's very effective, not only for schizophrenia, but also the patient with bipolar disorder. And they said that where the metabolic symptoms like weight gain and menstrual irregularity, there's been said to be very, very less with the aripiprazole LA, and where India is yet to be launched. When compared to the first and second generation LAA, according to the numerous studies, both first generation long-acting injectable and second generation long-acting injectable are equally effective. Efficacy-wise, there is no difference. Whether you give fluphenazine or paliperidone or olanzapine LAA, the efficacy-wise both are equal. Stone et al. Reported that the maintenance dose of schizophrenia, long-acting injectable of paliperidone, risperidone, haloperidol, fluphenazine were compared. They compared and they reported that they are equally effective in stabilizing the symptoms and also preventing the relapse. The first generation LAA have a greater incidence of extrapyramidal symptoms when compared to second generation antipsychotic. A meta-analysis by Castro and Critini et al. In 2023 is a recent report, meta-analysis report. They said that there is no significant difference in hospitalization, medication interruption, or mortality when compared to first generation and second generation LA. So efficacy-wise and hospitalization, everything was both are equally effective, but the choice should be based on the side effect profile and the patient acceptance and the price. So if you want to have a less side effect and the patient acceptance, second generation LA is very good. But it is not, first generation is not superior. We are using, as I said earlier, we are using routinely the fluphenazine deconate. Almost 500 injections per month we are using it. But you have to carefully choose patients as well as you want to watch for the extrapyramidal symptoms. Especially the patient may go for a irreversible TD. So that symptoms, if you carefully monitor and inform the patient about the extrapyramidal symptoms, you can safely use this fluphenazine deconate or fluphenazine or haloperidol deconate. Efficacy is very much is equally effective, and the only thing is the price is very low price, and also the only thing is they have a severe tardive dyskinesia, side effect EPS. If they develop an EPS, the patient may drop out from your follow-up. So that's the only disadvantage of first generation LAA. So regarding this long-acting injectable, there are many advantages there. They have a predictable and stable and sustained plasma level. There is low peak plasma level. There is less fluctuations. There is no first-pass metabolism. A missed injection is immediately known because we give every month. If the patient not coming, taken a month or 1 or 2 months, you can easily recognize the patient is on poor compliance, and it's a freedom from taking the daily pills. The time you give to BD or 3 times a day. So 3-4 tablets the patient has to take. That may not be occur when you give this long-acting injectable, and they have a frequent contact with the treatment team because with every injection they have to come to the hospital or nurses to give the injection. So you have a frequent contact with them, so you can have a good touch with the patients when you give LA, and also there is no risk of overdose. So it's with oral medication they may take overdose, but LA there is no risk of overdose. These are all some of the advantages of long-acting injectable. So there are, in the meantime, there are several barriers also to use these long-acting injectables. Like there is no prescribed guidelines for LA. So which are all the patients you have to use, which patient you have to choose. There's no clear guidelines to use this long-acting injectable, and doubts regarding the benefit than other than non-adherence. So many of the people, psychiatrists, they're using it only for the patient with non-adherence. Other than non-adherence, what are the other advantages? Still the psychiatrists have a doubt. And that's also they have a question regarding using the wider population, whether we can use it for LA, for pediatric population, whether it can old age people, or first episode psychosis, or bipolar disorders, whether it can use LA or not. So these are all the questions. Still there is a doubt, and debate is also there regarding the consulting on the safety of LA when compared to oral medications. And also they don't know the more effective way of convince the patients and caregivers to accept the LA. So LA is very costlier, and every month you have to give injections, and many people they don't know how to educate the patients to accept the LA. And another important barrier is the cost. Most of the second generation LA are very costly, more than 3,000, 2,000 rupees, or even paliperidone is more than 1,500 rupees. So this is one of the barriers. So despite the evidence that like LA long-acting gel is very effective in the early stage of schizophrenia, psychiatrists are very reluctant to prescribe the LAA and also very reluctant to accept them. Many clinicians regard them as, although they have been regard this LAA as effective, only less than 20% of the psychiatrists they are prescribing the LAA. Less than 20% of the patients they are receiving LAA, and only less than 10% of the psychiatrists they are prescribing LAA for their patients, especially in first episode psychosis. So there are many real-world study was there. One of the major studies published in 2022 last year in Clinic Journal of Psychiatry. It's a Canadian-based journal. They took almost 16,300 patients, and in that study, most of the patients were receiving the oral drug. The oral quetiapine was the first-line therapy. Almost 34% of the people they received oral quetiapine tablet, followed by respiratory tablet 27.7%, and olanzapine tablet 17%. Only 6.5% of the patients only received long-acting injectable. So out of 16,300 patients, only 1,062 patients only, that means only 6.5% only patient only received long-acting injectable. But the thing is that when the study was started in 2006, it was 3.9%. But after 10 years of the study was ended in 2016, and they found that it was increased 5.6%. It was increased to that level. So LA were rarely used as a first line therapy. If at all used, they used only as a third line and beyond third line only. So they also looked at the real world evidence of the clinical and economic impact of LA with oral antipsychotic drug, especially in patients with schizophrenia. And they found that LA had 20% less hospitalization and 14% less emergency admissions, and long-acting injectable were 18% more likely to adhere to the oral medications. And also they look at the resource utilization of the cost. So after 1 year of maintenance of olanzapine long-acting injectable, there is a decrease in 64.7% decrease in hospitalization, and 86.2% decrease in bed days, and 86.2% decrease in the inpatient service cost. So olanzapine long-acting injectable reduced the average bed days and hospital admission in patients with severe schizophrenia, which is economically very cost effective. And also they looked at the metabolic syndrome, that is one of the important side effects. They compared these metabolic syndromes, especially with the paliperidone formate and olanzapine long-acting injectable. They found that weight gain and triglyceride level was increased in oral olanzapine tablet than the paliperidone long-acting injections. So regarding the age, the increasing age, it does not affect the olanzapine or respiratory concentration following LA administrations. So the systemic exposure to olanzapine long-acting and respiratory long-acting is unaffected by age. In Sri Hospital, we are given almost 75 years old female schizophrenic patient. She is receiving olanzapine injection, and she was receiving almost for 3 years with no side effects. She was continuing, and she is tolerating also 300 milligram olanzapine long-acting. She was receiving for almost for 3 years for the chronic schizophrenia symptoms. So she is doing well. From a pharmacokinetic point of view, there is no reason to restrict olanzapine or respiratory long-acting in older patients who require a long-term treatment. Regarding the neuroleptic syndrome, the antipsychotic medication cause life-threatening NMS, and the recommendation to, when the patient develops NMS, the recommendation to immediately stop the antipsychotic agent. So NMS raised the question regarding the use in long-acting injectable. A recent patient-level meta-analysis of 662 published case report of NMS did not show worse outcome with second-generation LAA when compared with oral antipsychotic drugs. So we have to look for the risk-benefit ratio while choosing this second-generation LAA, and it's when you compare the risk-benefit, the LAA have a more benefit than the risk. So to choose for a patient with the chronic schizophrenic symptoms. So another important is Henry Nasrat et al. In an editorial in a current journal of Psychiatric journal, he has written an excellent message in an editorial. He says that psychiatrist should act like a cardiologist when treating a psychosis. Individuals who suffer from the heart attack are high risk of developing a second attack, which may lead to death or weaken the heart. So aggressive medical interventions needed to prevent the second cardiac attack, heart attack. Similarly, the first episode psychosis destroy millions of glial cells and the billions of synapses in the brain. So most of the first episode psychosis patients have a very high risk of developing a second psychotic episode. So second psychotic episode and frequent relapse can lead to more extensive tissue damage of the brain, gray matter and white matter, which in turn leads to clinical deterioration, treatment resistance and functional disability. So every episode, if the patient having a frequent episode, it like a heart attack patients, when they get repeated attack, the cardiac muscles become weakened and it destroy the heart muscle. Similarly, frequent relapse or frequent episode in psychiatric patients, they produce the damages of the neurons in a great level like a heart attack patient. So you have to treat the first episode psychosis like a heart attack. You should very aggressively treat the first episode patients, and you should give more importance to prevent the subsequent relapse, because subsequent relapse produce a greater disability to the patients in long run. In South Africa is a very famous study. South Africa, MC et al. Conducted a first study on long-acting injectable in first episode psychosis. After 2-year follow, 64% of the patients achieved a complete remission and they returned to their baseline functioning. At the end of the study, after 2 years, the study was over. All the patients who were there in the study of the long-acting were referred to the practicing psychiatrist. They referred to the psychiatrist who was being following for the follow-up. So this patient was referred to the study. Once the study was over, this is referred back to the psychiatrist in the local areas. And all the patients were switched over to oral antipsychotic drug because it was a standard practice among the psychiatrists there. Due to the poor adherence to oral medication, 98% of the patients relapsed within few months. When they were placed back on the LAA they have received, the shocking response is that 16% of them who had responded very well to the long-acting injectable, which they have been responding well and for a period of 2 years, when they were put back to the same long-acting injectable, almost 16% of the patients they become non-responders. So this shows the emergence of treatment resistance occur in a subsequent episode. So first episode itself we have to take great cautions and help the patient to prevent the patient not to get the subsequent episode. So regarding the evidence regarding the use of long-acting injectable in bipolar disorder and schizophrenic disorder is very, very limited. Clinical experience and evidence suggests that the use of long-acting injectable is beneficial for bipolar 1 disorder who has a non-adherence. Recently FDA approved aripiprazole long-acting injectable and risperidone long-acting injectable for the usage in bipolar disorder. Prajapati et al. In 2018 reported that second generation antipsychotic may improve the adherence in bipolar disorder and also it prevent the relapse. Isabel Prajapati et al. In 2019 done a meta-analysis of 15 studies. 6 of them are double-blind and 9 of them are open-label study, which were assessed for bipolar disorder and schizophrenic disorder. They reported that long-acting injectable prevent the manic episode, but not the depressive recurrence. Some patients, they notice that the worsening of depressive symptoms with long-acting injectable. Risperidone long-acting injectable was found to be effective in protecting from manic symptoms compared to placebo, but not from the depressive recurrence. Add-on monotherapy for paliperidone in schizophrenic disorder patients to protect them from psychotic, depressive and manic symptoms. In patients with bipolar 1 disorder, with the manic episode, aripiprazole monohydrate significantly delayed the time to recurrence of the manic symptoms without inducing the depressive episode. So the clinical evidence shows that long-acting injectables were effective and well tolerated in maintaining the treatment of bipolar 1 and bipolar 2. This is a second generation antipsychotic. So second generation LAA showed a better efficacy in preventing the mania than the depressive episode. So LA can be considered as the first line treatment for bipolar 1 disorder, schizophrenic disorder who has a predominant manic polarity and also who has a good adherence. So it's a take-home message. So there are a lot of advantages for this long-acting injectable. Still, it was been underutilized by a psychiatrist. So you should choose this long-acting injectable for a patient who has non-adherent to oral, and the patient you should use it for a first episode psychosis, and prevent the relapse and decrease the hospitalization and re-hospitalizations, and also they prevent the brain damage and the consistent drug delivery and drug monitoring, and also increase the patient for turnover, because they will, whenever choose the long-acting injectable, they will have a practically I found that overall you put the patient on long-acting injectable, they have a good follow-up and they put adherent to the medications. So in turn, your practice also will pick up, and because the patient will definitely come if they are feeling better, they have no recurrence, they will come back to you. So it will increase your patient turnover. So all these things, the way forward is long-acting injectables. So consider long-acting injectables as early as possible. Don't delay it later. And whenever you found the patient is having, you want to prevent the subsequent episode, always choose, give priorities to long-acting injectables. Issue a treasure. So nowadays, many companies are coming out with a very low price. When compared to the price and the recurrence, they don't treat the patient. The patient may get a recurrence. They will get admitted. Then you have to give the dosage. You have to give a high dosage. That itself will be highly expensive. Another thing is, many scientific evidence shows that it produces a brain damage. It produces a significant impairment in the quality of life of the patient if they get second or third episode. So prevent all these things. Please consider this LA as in a priority. Thank you very much for the audience for giving the opportunity. Thank you for the organizers.